Multiple sclerosis (MS) is an autoimmune disease characterized by inflammation, selective demyelination, and gliosis. It causes both acute and chronic symptoms and can result in significant disability and impaired quality of life. MS affects approximately 400,000 persons in the United States, and worldwide MS affects approximately 2.1 million people. It was first defined by Dr. Jean-Charcot in 1868 by its clinical and pathological characteristics: paralysis and the cardinal symptoms of intention tremor, scanning speech, and nystagmus, later termed Charcot's triad. Using autopsy studies he identified areas of hardened plaques and termed the disease sclerosis in plaques. The onset of MS typically occurs between ages 20 and 40 years. MS is rare in children, as is the onset of symptoms in adults older than age 50 years. The disease is more common in women than in men by a ratio of 2:1 to 3:1. Although the incidence and prevalence of MS overall have increased over the last 5 decades, this increase appears to be mostly related to an increased prevalence in women. There are also ethnic differences. MS affects predominantly white populations. African Americans demonstrate approximately half the risk of acquiring the disease. Low rates are also reported in Asians and Native Americans. Etiology: the risk of MS is increased in persons with an affected family member. The risk is 3.0% for a sibling, 5.0% for a fraternal co-twin, and rises to 25.0% for an identical co-twin. Genetic studies have revealed many interacting alleles that may contribute to MS susceptibility, with mutations in the human leukocyte antigen major histocompatibility complex (MHC) gene most strongly correlated. It appears that although individuals do not inherit the disease, they may inherit a genetic susceptibility to immune system dysfunction. When persons with a genetic susceptibility are exposed to a viral agent, the immune system responds with activated myelin-reactive lymphocytes, a concept known as molecular mimicry. Implicated viruses in this process under investigation include the Epstein-Barr virus, measles, canine distemper, human herpesvirus-6, and chlamydia pneumonia, though none have been definitely proven to trigger MS. The viruses may be retained in the body, resulting in a self-perpetuating autoimmune process. The risk of MS may also be increased with vitamin D deficiency and smoking. 4 major clinical subtypes of MS. Relapsing remitting MS (RRMS), characterized by discrete attacks of neurological deficits, relapse, with either full or partial recovery, remission, in subsequent weeks to months. The periods between relapses are characterized by a lack of disease progression. The stable patient may have a local inflammatory activity that is clinically silent. Affects approximately 85% of patients with MS at diagnosis. Secondary progressive MS (SPMS), characterized by an initial relapsing remitting course, followed by a change in clinical course with progression to steady and irreversible decline with or without continued acute attacks. May be the result of progressive axonal loss rather than new lesions. Before newer treatments, the majority of patients with RRMS progressed to SPMS. Primary progressive MS (PPMS), characterized by disease progression and steady functional decline from onset. Patients may experience modest fluctuations in neurological disability, but discrete attacks do not occur. PPMS is associated with later onset, mean age 40 years, and more equal gender distribution. Affects approximately 10% of patients with MS. Progressive relapsing MS (PRMS), characterized by a steady deterioration in disease from onset, similar to PPMS, but with occasional acute attacks. Intervals between attacks are characterized by continuing disease progression. Affects approximately 5% of patients with MS. Common symptoms in multiple sclerosis. Sensory symptoms: hypoesthesia, numbness, paresthesias, pain, paroxysmal limb pain, dysesthesias, headache, optic or trigeminal, neuritis, Thermid's sign, hyperpathia, chronic neuropathic pain, visual symptoms: blurred or double vision, diplopia, diminished acuity, loss of vision, scotoma, nystagmus, lateral gaze palsy, cognitive symptoms: short-term memory deficits, bowel symptoms: diminished attention, concentration, diminished executive functions, diminished information processing, diminished visual, spatial abilities. Affective symptoms: depression, anxiety, pseudobulbar affect, anxiety. Motor symptoms: paresis or paralysis, fatigue, spasticity, spasms, ataxia, incoordination, intention tremor, postural tremor, impaired balance and gait, speech and swallowing, dysarthria, diminished verbal fluency, dysphonia, dysphagia, bladder symptoms, spastic bladder, flaccid bladder, dysenergic bladder, constipation, diarrhea and incontinence, sexual symptoms, impotence, decreased libido, impaired ability to achieve orgasm, pattern of symptoms, varies greatly from person to person, varies over time in each individual affected. First symptoms usually transient, typically sensory and visual. Diagnosis. The diagnosis of MS is made by the neurologist based on a careful medical history, a complete neurological examination, and supportive laboratory tests. Evidence of damage must be present in at least 2 separate areas of the CNS, dissemination of lesions in space, and damage must have occurred at 2 separate points in time at least 1 month apart, dissemination of lesions in time. In addition, other possible diagnoses must be ruled out. The revised 2010 McDonald criteria of the International Panel on Diagnosis of MS has resulted in earlier diagnosis of MS with improved specificity and sensitivity. Laboratory tests used to help confirm the diagnosis include magnetic resonance imaging (MRI), evoked potentials (EP), and lumbar puncture (LP) with cerebrospinal fluid (CSF) analysis. MRI is highly sensitive for detecting MS plaques in the white matter of the brain and spinal cord. New lesions with active inflammation that occur during the preceding 6 weeks or so are seen as areas of increased signal intensity, bright spots. Contrast-enhanced T1 weighted images, gadolinium-enhanced, are used to detect more long-term disease activity, i.e., loss of myelin and axons, gliosis. These lesions are seen as black holes on the MRI. The darker the lesion, the more extensive the tissue damage. Approximately 95% of patients with clinically defined MS have well-defined MRI changes.